All right, well, to begin with, I chose this topic because of a few reasons. One is working in a sinus clinic, we see a lot of patients with postnasal drainage, or at least complain of postnasal drainage, and then when you see them, you don't see the postnasal drainage. The opposite is also true in terms of when patients don't complain of postnasal drainage, you look in their nose and you see pus draining down the back of their throat, and then you ask them if they cough and they say no. So one of the things I wanted to get out of this was pulling the research myself and looking at the research. And what I found is that it's very controversial, and that most of the articles would end with the conclusion that future research is necessary, but I just don't see that future research. So for the objectives today, we're going to identify common etiologies of chronic cough. We'll describe the workup relevant to chronic cough, review treatment options, and highlight these areas of controversy. And we'll begin with a case report. A 35-year-old female presents to your clinic with a non-productive cough for 3 months. The cough is initiated with a bout of bronchitis. She coughs during the day and the night. Relieving factors are none, and exacerbating factors are exercise. On review of symptoms, she talks about sneezing and congestion. The remaining symptoms are negative. She has allergic rhinitis. She denies tobacco exposure or use, and medications are none. She has a negative PPD, and her pertussis booster is up to date. On physical exam, you see turbinate hypertrophy. These aren't polyps, but when you look in the nose, you see the septum on the right and the turbinate on the left. This would be the right nasal cavity. There's thick mucus, and the turbinate's inflamed. The remaining exam is negative, so you diagnose allergic rhinitis, you treat her with nasal steroids and antihistamines, and tell her to come back in 6 weeks. So she comes back and says there's no improvement. You get new information that the cough is preceded by a tickle. It's worse after lying down and resolves with standing. She has brief nighttime stridor, and she says it feels like the throat is closing off at night. She also reports fluctuating hoarseness. So you send her to the ENT doctor, and we perform nasopharyngoscopy. So with nasopharyngoscopy, we're looking specifically at the voice box. We can rule out masses, and we're looking for findings of reflux. And in this patient, you see in the back the esophageal inlet. Those in front of that is the posterior commissure. So that would be that level right there. And then the voice box in front of that, and then the bottom of the picture, you're looking at the epiglottis. If you ever search through our EMR notes and you can find the exam, you're going to see things like subglottic edema, posterior commissure hypertrophy, false chord swelling, true chord swelling, and endolaryngeal mucus. And these are the things we're talking about. Posterior commissure hypertrophy is a common finding. So now we diagnose her with laryngopharyngeal reflux, cough hypersensitivity syndrome, treat her with proton pump inhibitors, diet and lifestyle modifications, and speech therapy. And in 2 months, she follows up and says there's resolution of symptoms. So chronic cough is defined as a cough greater than 8 weeks in an immunocompetent patient without clinical or radiographic evidence of lung disease. It's greater than 4 weeks in the pediatric population. Refractory cough is cough that does not respond to usual medications. This is seen in 20 to 40% of patients. An idiopathic cough is a cough without an underlying cause after a thorough workup. Again, 20 to 40% of patients. Chronic cough is a significant presenting symptom. It affects 12 to 16% of the general population. It's the 5th most common complaint driving patients to seek care in your office, and there's significant cost. Over-the-counter medications alone result in $7 billion being spent per year, and there's significant morbidity. Quality of life studies demonstrate disease burden similar to asthma, diabetes, and depression. There's significant physical, psychological, and social issues. Physical issues may include emesis, stress urinary incontinence, syncope, bradycardia, chronic laryngitis, pneumothorax, and rib fractures. Psychologically, these patients may talk about debilitating depression, anxiety, stress, and guilt. In a social standpoint, they're embarrassed, they have worried family members, and it disrupts their activity or enjoyment of social activities. So for this talk, we're going to talk about an immunocompetent patient. Assume they have a negative chest x-ray, no tobacco history, no significant environmental irritations, no use of ACE inhibitors, and no red flags. Red flags for a cough would be hemoptysis or constitutional symptoms. Okay, in the literature, the common etiologies are reactive airway disease or asthma, reflux disease, and rhinosinusitis. Okay, this is the pathogenic triad of chronic cough. These account for approximately 80 to 90% of the cases. But this is old literature. And in the past decade or so, we now have a new cause called sensory neuropathic cough, or cough hypersensitivity syndrome. And this is one of the things I find interesting about chronic cough is this fourth cause. Some of the things that make chronic cough difficult to diagnosis is in up to 25% of patients they'll have multiple etiologies. There's a high prevalence of these common etiologies associated with chronic cough, and this dilutes the results of diagnostic testing. And what this means is that patients may have allergies, they may have sinusitis, they may have reflux, but that does not imply it's the cause of the cough, just like we saw in our case example. All common etiologies may present with cough as the only symptom. All may have no clinical findings. So thus, clinical practice guidelines recommend empiric medications. So important historical data to get is the cough productive? Is it in the day, night, or both? Was it preceded by an upper respiratory tract infection? Is there association with food and liquids? If people cough with liquids, it implies perhaps aspiration, and aspiration these patients should have their vocal cords looked at. Are there positional issues? And most important, triggers. I find triggers to be very helpful. Environmental irritants such as perfume or strong odors, cold air, physical stimulants like talking, singing, and laughing. These will suggest your diagnosis. On review of systems, we'll talk about hoarseness, globus, postnasal drainage, and sinonasal symptoms. Dr. Reel will be talking next about sinonasal symptoms, but real briefly, congestion, nasal drainage, smell abnormalities, and facial pressure specifically. GI symptoms, dysphagia, heartburn, dyspepsia, and sour taste. Pulmonary symptoms of wheezing, dyspnea, and chest tightness. Dermatology symptoms may suggest allergies. And just one quick comment on postnasal drainage. There's not a true definition of postnasal drainage, but for me, it's the sensation of mucus in the throat. It doesn't imply it's coming from the nose. It doesn't imply it's coming from the sinuses. And again, it's a sensation because most patients actually don't have it. On physical exam, you want to look at the ears and the nose and the throat and auscultate the chest. In terms of the ears, there's a reflex that we'll talk about, so just make sure there's no foreign bodies. Nose, congestion and discharge, throat, especially the oral pharynx looking for postnasal drainage, and lymphoid hyperplasia that you refer to as cobblestoning and that we see here on this patient. There's lots of pulmonary etiologies, but we're focused on asthma and cough variant asthma. Again, like all these etiologies, cough can be the only symptom. In terms of diagnosis, again, start with a chest x-ray, and if you suspect asthma, pulmonary function test, but clinical practice guidelines suggest just trying inhaled or systemic steroids to diagnose the condition. A few topics about cough variant asthma. It often worsens at night and in the early morning. It can be exacerbated by upper respiratory tract infections, just like our other causes. Diagnosis requires documented resolution of the cough following the treatment with steroids. And a word on anti-leukotriene esterase inhibitors. These have been found to be helpful in chronic cough, especially when given for cough variant asthma. The studies demonstrate an effect within 1 week of treatment. It requires up to 4 weeks for a maximum effect. But on the package insert, coughing is a common side effect of these medications. Reflux is the most controversial. Okay, this can be caused by acidic or non-acidic reflux. This is a very important thing in ENT, is that the reflux could be non-acidic. It may be direct irritation of the vocal cords, or it can be a vaguely mediated reflex from distension of the esophagus. Heartburn occurs in 20% of North Americans, and the percentage of cough attributed to reflux ranges from 10 to 90%. And this is what we see a lot in the literature, is this wide variation suggests that we just don't know how to diagnose it and how to prove that it's a cause and effect relationship. And to make matters more confusing, GERD is silent in up to 60 to 70% of cases. So this becomes a very controversial topic. Okay, and then when it only affects the upper aerodigestive tract, we call it LPR. These symptoms would include throat clearing, excessive mucus production, postnasal drainage, globus, hoarseness, wheezing, and dysphagia, and of course cough. 50% of patients with LPR will have cough as a primary symptom. Lots of diagnostic studies, and there is no gold standard. But the closest thing would be a multi-channel intraluminal impedance pH monitoring test. Okay, what that means is you're measuring pH along with pressure changes in the esophagus. You can correlate this with the cough so that a patient has a button they push when they cough, and is it related to the reflux. 50% of patients with chronic cough have GERD findings on pH testing alone. But this testing is controversial, and again, guidelines suggest empiric treatment. So again, nasopharyngoscopy is one of the the diagnostic procedures that we can perform at the patient's initial evaluation. Here's a nice demonstration on the left of what a normal larynx would look like, and on the right, somebody with potentially reflux. This is not specific. These findings are not specific, and so it does not definitively diagnose LPR, but when you get a report back from us that says LPR, this is why we're making that decision. Treatment includes twice-daily proton pump inhibitors, antihistamines, prokinetic agents, and baclofen. Okay, out of all these, only proton pump inhibitors have been looked at with respect to cough as an outcome, and these results are equivocal at best. Diet and lifestyle modifications have been looked at. Diet includes refraining from reflux-inducing foods, but also alkaline water. Lifestyle modifications, I find head of bed elevation to be the most important, and studies have demonstrated benefits with these changes. Nissen fundoplication has also been demonstrated to be effective, specifically looking at chronic cough from reflux in 2 different studies. The U.S. national economic burden for LPR is significant. $50 billion is spent annually compared with 9 for typical GERD. Treatment for chronic cough with proton pump inhibitors is not as good as it is with traditional GERD symptoms, and we'll discuss some reasons why. 30 to 50% of patients with chronic cough do not respond to proton pump inhibitor therapy. And again, that's twice daily. So recently, a Cochrane review concluded that there is insufficient evidence to conclude that proton pump inhibitors are effective in treatment for idiopathic cough. And despite that, we still use it, and we do see benefit. Okay, the treatment failures, these are the reasons. First is noncompliance. For just traditional GERD, 40% noncompliance rate. And a lot of that has to do with the fact that proton pump inhibitors are getting a bad rap, deservedly so. The duration of therapy in LPR is longer than the duration of therapy for typical GERD. So most studies in our literature would suggest a minimum of 3 months of therapy, despite the package insert you see on the right saying do not do this for more than 2 weeks. All patients come in and say, I tried this for 2 weeks like it says, and it didn't work. That does not mean they have failed that trial. Incomplete acid suppression. Some proton inhibitors may affect patients differently, and most importantly, non-acidic reflux. Okay, so that means that you can be suppressing the acid all you want, but they're refluxing pepsin or something else into the throat. And finally, there may be an association but not a cause, and what this means is most people that cough will have reflux. It doesn't mean the reflux is causing the cough. The third cause is rhinosinusitis. In the literature, this is referred to as postnasal drainage syndrome or upper airway cough syndrome. I don't like either of these terms because it's not describing what you're diagnosing. So is it a form of rhinitis or is it a form of sinusitis? And again, the incidence of rhinosinusitis as a cause of chronic cough is 26 to 78%. Again, because we just don't know how to accurately diagnose it and prove a cause and effect. And again, make matters worse, it can also be silent in 20% of cases. And I don't really describe how they come up with that number. Allergic rhinitis affects up to 30% of adults, 40% of children. Again, treatment is nasal steroids, antihistamines, and allergy immunotherapy. Only antihistamines have been looked at with respect to cough as an outcome, and it demonstrated a reduction in the intensity and frequency of cough. But allergy immunotherapy has not been looked at to successfully take away somebody's cough. Treatment for rhinosinusitis will be talked about next, but just briefly, saline irrigation, steroids, antihistamine, decongestants, antibiotics, and sinus surgery. And none of these have been looked at, again, with respect to cough as an outcome. To make matters more confusing, here's 2 studies that muddy the water. So the first one was by O'Hara, and only 21% of patients with purulent postnasal drainage complained of chronic cough. So you take this patient on the right here who you see this drainage This is the back of the nose draining into the nasopharynx, and 79% of these patients would say they don't have a cough. Okay, in another study, same type of patient, chronic cough and documented postnasal drainage on exam. These patients were treated with proton pump inhibitors versus a placebo for 90 days, and the patients who were treated with the proton pump inhibitors had a significant reduction in both the postnasal drainage and the cough. Okay, and this is the one that I find most interesting and most commonly overlooked. This is neuropathic cough. This was first described around the turn of the century as irritable larynx. It has a bunch of other names, commonly post-viral vagal neuropathy. You can think of this as a neuropathy of the superior laryngeal nerve or recurrent laryngeal nerve, which are branches of the vagus nerve. Basically, this is the final common pathway of many of the traditional causes. This is why not everybody with allergies or sinusitis cough. It's reported to be as high as 31% now of chronic refractory cough patients. It also is associated with dysphonia, dysphagia, dyspnea, and vocal cord abnormalities on laryngoscopy. These patients typically present with a non-productive cough with onset after viral illness or trauma like intubation. This has similarities to other cranial nerve neuralgias. It's a sensory neuropathy as opposed to a motor. So it has recognized trigger phenomenons, which we discussed, such as talking, laughing, strong odors, and smoke, and it responds to neuropathic modulators. And most interestingly, it's associated with vocal cord dysfunction, such that a high percentage of patients with vocal cord dysfunction have cough, and a high percentage of patients with cough have vocal cord dysfunction. Okay, the neuropathic modulators include narcotics, amitriptyline, gabapentin, and baclofen. There's been case reports of Botox, and speech therapy recently has been found to be effective for these patients. My preferred method of starting out is amitriptyline. I start with a low dose of amitriptyline. They take it at night. I tell them it may take 6 weeks for this to demonstrate benefit, and this has been proven effective in controlled studies. This was compared with codeine and guafenicin, and there was a significant difference. These patients have high amount of side effects, dry mouth, sedation, and postural hypotension, but rarely serious side effects. And that's true of all the neuropathic cough treatments. Side effects are common but rarely serious. I tell them I anticipate 6 months of therapy. I taper them on the medication. They always need to be tapered off. And I titrate medications to effect. So I don't tell them they have to go to 30 or 40 milligrams. They stop when they notice a difference. If you take nothing else from this, I would read this book. So this book is called The Chronic Cough Enigma by a laryngologist in our field. And it goes through, kind of in layman terms, simple terms, on how to understand LPR and neuropathic cough in terms of how they are creating these problems. Some other less common etiologies, of course, are the cough-exacerbating medications, the most common of which are the ACE inhibitors. Just briefly, 10 to 15% of patients on ACE inhibitors will have a cough at some point. It can occur anytime during treatment, and it may take several months to resolve once you stop the medication. Obstructive sleep apnea can also present with chronic cough, and this can be the only symptom of obstructive sleep apnea. 33% of patients with sleep-disordered breathing had chronic cough as a primary symptom. And interestingly, they also have a high prevalence of GERD and rhinitis, and much higher than the general population that you see here. This is an interesting cause of cough, is the Arnold's ear cough reflex. Okay, so this is a neuropathy of the auricular branch of the vagus nerve. It can be a true neuropathy, or it can be from a foreign body. This is the reason why you look carefully in the ear. When we're cleaning wax out of the ear in the clinic, frequently patients will start coughing. Psychogenic cough. This is also referred to as habit or tic cough. There's an absence of it during sleep, but this is not specific, as other causes can be absent during sleep, such as neuropathic cough. These are low-quality studies, usually in kids or adolescents, and most of these case reports never considered cough hypersensitivity or neuropathic cough. Tonsillar hypertrophy, turbinate hyperplasia, and nasal septal deviation are listed in the literature, but I don't find these to be helpful at all. I don't recommend surgery, and I don't discuss this as a cause of their chronic cough. And then lastly, speech therapy. This has been found to be effective in 2 different controlled studies. It's based on the same treatment that we treat hyperfunctional voice disorders, such as vocal cord dysfunction. There's a multimodality approach, and it usually requires about 3 to 4 sessions over 1 to 2 months. So it's a quick form of therapy, and like I said, significant benefit. I think for neuropathic cough, these patients probably should be looked at prior to proceeding with this. Looked at meaning their voice box should be evaluated. So in summary, chronic cough is a common debilitating condition. There are limited history and physical exam findings to solidify a diagnosis. Initial diagnostic studies would consist of a chest x-ray and when an asthma suspected pulmonary function test. Clinical practice guidelines recommend sequential empiric therapy based on the common conditions. And if this is done, you get about a 70 to 80% effective management of these patients. Don't forget that multiple causes exist in the same patient. Don't overlook neuropathic cough, and consider referral for refractory cough to one of many specialties that deal with this condition. Thank you. Tim. Pardon?
How common is the neuropathic cough?
Well, it's never been looked at. But if you look at these case reports, these patients have similar findings. They don't cough at night. They're preceded by a tickle. And almost always the parents will say they had a cold when it started. So I think it's very similar, but they've never been looked at specifically, and they don't treat with the same medications.